Thank you very much. Thank you for inviting me. So I will be talking about our fight against tuberculosis using repurposing atorvastatin in Nigeria. Of course, we know TB is the main infectious disease cause of death globally. Even in the era of COVID, TB was still the leading cause of death. Now that COVID has gone, we see having death rate from TB is still high globally. And in Nigeria, Nigeria, one of the biggest populated country in Africa with over 200 million population. And interestingly, Nigeria also has one of the big hotspots for TB globally. We have the 6th position in global TB burden and has the highest TB burden in Africa. One big thing about TB is that it affects the most economic productive age group. So it could be said to be a disease of poverty, but if you are this group, it also encourages cycle and perpetuate poverty. Of course, there are treatments for TB in the hospitals, in the communities based on DOTs. But of course, this has quite a lot of limitations. Now, we have TB treatments that I'm sure we are quite familiar with, and some of these treatments have been on for more than 6 decades, and new drugs are also being developed. But we have quite a lot of challenges with present drugs based on our experience in seeing patients and clinics and all the rest. These drugs are multiple to form regimen that goes on for a long period of time, for about 6 months, sometimes now 4 months. The 4 months regimen are fairly expensive and not really accessible to everybody. And then we have the issue of non-adherence, which is the big issue that's a big factor for resistant development. It ranges from about 25 to 35%. In some other series, it's actually higher than that, which is a big issue because you have to take the drug every day, first thing in the morning on an empty stomach. It's a big issue. And of course, we have the issue of relapse and recurrence rate, which in our own study is about 3.2 to 14%, but other workers are reported as high as 25%. These mean individuals who are treated and then develop TB again. And this is a big issue that we are having. Of course, treatment success rate ranges about 80 to 90%, which is good. But the 10% that failed, if you convert that to the population, and if we know that by the time you are seeing the patient in the clinic with TB or anywhere, they have already infected about 14 to 20 people. So that 10% is a lot of number. And so we can't eradicate TB without taking care of that. And now we have a big problem of what we call post-TB lung disease. That's a big problem globally. Now we have millions up to 50 million people who have been treated for TB, cured. You take their sputum culture, they are negative for TB, and they don't have any problem. But 2, 3, 4, 5 years down the lane, they begin to have problems, respiratory problems, referable to the TB, but not TB again. And this is a big problem that is consuming healthcare utilization and impairing the quality of life of people. And this is what we see every day. And every time we begin to say TB again, TB every time. And so post-TB lung disease costs about 122 million, generally TB, disability life years. But post-TB lung disease costs about 58 million disability life years on its own. And this is a big problem. And we used to refer to it as the booming and the coming epidemic. And so we think something must be done in that regard to address the issue of post-TB disease, to address the issue of non-adherence and high default rates that the patients are having. And so we look at atorvastatin. Statin is a drug that's very common there, is available everywhere. Everybody uses it, a large number of people use it to lower their cholesterol. It's an HMG-CoA reductase inhibitor, but that's the main purpose for the drug. But we also do find out that atorvastatin has other effects. It is a pleiotropic drug, has antibacterial, antimicrobial tuberculosis effect, okay, in the large number of cases which has been demonstrated. And there are various forms of statins. We look at atorvastatin. Atorvastatin is the highly lipophilic form of it. Rosuvastatin is also there, but not as highly lipophilic as we have in atorvastatin. And in many cases, in vitro studies in animals and case control studies, necessary studies have demonstrated statins' effect on TB. patients who have diabetic and they look at their register, those on astatine, and they look at the incidence of TB in them, we found out that it was very low. And so for statins is known generally to reduce bacterial load, to shorten treatment duration, and also decrease relapse rate. We know statin also reduces the availability of cholesterol. The MTB organisms require cholesterol to form the cell wall. And so this reduction in statin in cholesterol level has been known to disrupt MTB and make it easily to be susceptible to be killed. And then it also enhances the permeation of anti-TB drugs into this organism. It's also been demonstrated that statin can actually cause a direct apoptotic effect on the organism itself. So all this gave us some confidence to look at the beneficial effect of statin in human. And I dare to say we probably conduct the first ever human trial, to the best of our knowledge, on atorvastatin. Though at the time we are publishing our first study, we realized there was another study that looked at rosuvastatin, but had a very completely different result. So we present what we called ATOTOP, which is atorvastatin in pulmonary tuberculosis, which is the first human trial with atorvastatin. Was initially designed as a phase 2A study, but we are now hoping to move on to phase 3. We've done phase 2A, phase 2B completed. Then we are just completing phase 2C study now, and then hoping to move on to phase 3. And then was registered, and they were all on the clinicaltrial.gov. The main goal of this trial was to determine the safety and efficacy of atorvastatin in pulmonary tuberculosis, and our overall goal is to move this to have a global impact. Now, this was done during the COVID, and you can see we have a lot of people at the commencement of the trial. You can see them in mask. So we started the trial during the COVID era, at least in our own setting, and that involves a lot of patient group, TB programmers in our community, hospital administrators, pharmaceutical groups as well as some of our research or whatever. The good thing about it is like this initial proof of concept study was funded by the Cures Within Reach, which presented earlier in the morning. And then from there, we move on and we're able to secure some follow-up funding for phase 2C, or hopefully for phase 3 from Open Field and from anybody else in the room. We're open. So now our trial, we are just going to elaborate the power of collaboration and how we drive the community to achieve this. All of the studies were done in Nigeria. Get to know, virtually all the study aspects were done in Nigeria. The only aspect that we didn't do in Nigeria is the PK study. Though we collected all the specimens, was being shipped to South Africa for analysis. Okay. And then virtually all the study teams again, we are basically Nigerians, trained in Nigeria now, all with some input in different parts of the world, but we are homemade, home group, solving our problem. It's a multidisciplinary and transdisciplinary group consists not only physicians, but nurses, public health workers, patient groups, TB programs in the Ministry of Health, and everybody were involved in this. And then we generally have a meeting monthly to discuss progress, address challenges, and then move on. The trial also provided a very unique opportunity to train a large number of people in clinical research, which we may be quite well familiar with. Now, we are able to recruit up to now, all through the phase of the study, about 600 TB patients, and we are following them up for a variable period of time at the moment. One good thing about us is that we collect our specimen and process them as centralized lab. We have 8 different labs scattered all over Nigeria. So you can imagine the sputum, the blood were collected and processed in centralized lab. And of course, we have a community-based system to ensure that patients are followed up and we do not have a lot of default. These were done to the patient advocacy group and TB survivors that we have. We have an organized system, and I would say we also have an electronic reporting system, and then we have a logistics for shipment of specimens from different centers, and then we secure ethical approval. Now, just give you a rundown of some of our field results. We've demonstrated that atorvastatin at various doses, 20, 40 milligram, and even 6 that we are doing on it, is relatively safe in most patients. and we have about less than 10% default rate. We've been able to build clinical research capacity among our individual, and then we believe we're able to engage the community and provide for them more education about TB and awareness about clinical research. Now the drug is available for off-label use, at least by some patients who are ready to use it on their own. And the drug potential of atorvastatin to actually be used also in drug-resistant tuberculosis has been brought to the fore from many of our studies and research that I will show off. Okay, so this is our first study 2A that shows atorvastatin is highly bactericidal activity. And as you can see, it has highly bactericidal activity. This was a phase 2A study that shows that a very significant result from that. And then from phase 2B study, it shows atorvastatin do not only enhances clearance of mycobacterial tuberculosis, it does also improves chest X-ray, chest X-ray severity. Individuals who are on atorvastatin on this phase 2B study had an improvement in their chest X-ray compared to those who are not atorvastatin. So we can see that, yeah, okay, so this is just, yes, we saw the sputum conversion, but either by protocol analysis or by intention to treat is better in the atorvastatin group compared to this other group. And then with atorvastatin was generally safe in all of our studies. We don't have any issue with myositis. That tends to be a major issue, and CPK in them was not really remarkable. This is a preliminary result from our phase 2C study that shows the potential of atorvastatin in lowering stable conversion to about 3.4 months, and we conclude that could potentially be used to shorten treatment duration. This is still going on. So these are some of the perceived challenges in repurposing in the LMICs. It's believed that we don't have inadequate resources. That may be true, or expertise. That may not be true. Uncertainty about value, liability risk are issues that have been raised. Organizational barriers and poor coordinations are why sometimes you don't have trial coming in LMICs, and then lack of clarity of risk benefit. But we're able to overcome all of this through collaboration. This is our hospital where the study was conducted. This is one of our team members and settings where we have it, and then this is some of the training sessions that we have. We collaborated with National TB Reference Lab, which is WHO accredited lab, for the study to be done. And so we did all of this because we work together as a team and we collectively work together to fight TB. We have institutional collaboration. Where we don't have facilities in our own center, we collaborate with other institutions where that is available. We have a collaboration with ethics approval. We work with TB programs, and actually even work with WHO. Recently, we have a meeting with WHO. We talked about this, and they were excited about it, and we're looking for data to see how this could be included in the guideline. Also, we have constitutional collaboration for training, logistical collaboration. We work with private sectors, for example, in shipment, in current specimen, we do that. We take that up completely of us, and then strategic partnership for funding. That wouldn't have happened without funding. Your idea will perish with you without funding, especially LMICs. So we have strategic partnership that give us funding, and then community engagement. We've been bringing all on board, and patient advocacy group and survivors were also instrumental to our success. And so this is also one of the meetings we're having in as part of our advocacy and all the rest. So I would say the purpose of atorvastatin is bringing new hope and effective strategy to TB treatment. And strategic and institutional collaboration, were helpful. And I would say research output from low, medium income countries could have great potential for discovery and policy change and impact with a very strong value for money. But I would say that collaborative approach, including funding program, should be considered. Thank you, and this is an acknowledgement. And I want to say, you may want to put your name again as a founder on this acknowledgement. We'll be happy to have you. Thank you very much. Thank you.